Okie dokie. So we're gonna go ahead and dive on in. I have a few more slides to go over, and then we have a group assignment to do. And there were a lot of readings, so what I'll do is I'll divvy them up. Divvy up the questions for each group. We'll just do 1 or 2 questions. Alrighty. Go ahead and minimize this. Good question. Let me back out real quick. 45.
I only have 40.
Oh, that's weird. If I haven't done it already, I will go in and put the links to these on there. And it might be, I added some slides for the videos, so this might be like a couple slides back. Alrighty. So we have been talking about Ellis and Beck's approaches and sort of the cognitive approach to psychopathology and personality and how do we treat it based on that. And so this is the cognitive model, and this is like in a very traditional CBT type of setting, how you would actually present it to a client as well. So again, it's the situation that's activating your automatic thoughts, and that's what's leading to your consequences. Hang on just a sec. I'm actually gonna try to make this legible. Hey, there we go. Okay, good. It's not the situation leading to your consequences, right? Those ABC sheets that we looked at. So, and then the idea is that those automatic thoughts are being activated by whatever your core beliefs are. I'm unlovable. I must be perfect in order to be loved. Things along those lines. So those are going to lead to your problematic emotions, behaviors that you don't understand why you're doing, and then physiological responses. So, you know, for depression, this might be moving more slowly, having changes in appetite, having changes in things like your ability to sleep. I was just talking with my intro class before this about panic, right, and anxiety. And certainly physiological responses are much more clear there, where you're going to have increased heart rate, right? All the symptoms of breathing changing, physical shaking, numbness, dizziness, things like that. And so the idea is that by starting to recognize the automatic thoughts and changing them, challenging them, disputing them, if we want to use Ellis's terminology, then we can start to change these consequences. And then eventually when we get good enough at that practice, we can go down and start challenging those core beliefs. So this is the spiral model, which is another way that we might present it to clients. And the idea here is that your event, that whatever you experience, that activating event, that situation, that's going to lead to your cognitive appraisal, those thoughts and beliefs you have about what's going on, which in turn will be linked to your emotions and your behavior, and your behavior and its consequences are going to be linked back up to your emotion, to your thoughts, as are your emotions. And then just as we've talked about when we talked about reciprocal determinism, that how you behave is going to influence the environment around you. and then, feed back into this spiral. And so the idea is we want to break that spiral. We want to start challenging these so that we don't get these negative consequences. And one thing I don't think I've emphasized enough about both RET and CBT is it's not about thinking positively. It's about thinking realistically. So like one video that I've seen where Aaron Beck works with a client, she's like, well, I expected my marriage to last. And he's like, well, is that a realistic expectation given the divorce rates? And you're like, whoa, right? But that's the idea. We're not just going to be like, oh yeah, you totally should have, right? It's like, well, we need to think about what's realistic to think. And like right now, right? Like I've shared with you all, I was working with the therapist I worked with for postpartum depression into the pandemic, and then we were able to end. But there were times where we were just like, yeah, it's really normal to just feel awful right now because things are awful, right? And like that's okay in its own way. So cognitive therapy is empirically supported. So again, Beck really wanted to do research about it. This became the crux of cognitive therapy in general. This is the mission of the conference that I'll go to in a couple weeks, the Association for Behavioral and Cognitive Therapies. The idea is that we're going to do research and make sure it's actually working. And then once we do that, we're going to try to figure out why it's working. And then if we can figure out important components, then we can just boil therapy down to those. So they're usually tested a lot before they're written up in formal manuals. And so manualized therapy, you can just be trained in general CBT, but if you are treating a specific disorder a lot, or you're doing research on a therapy, then you get specialized training in the manualized version of the therapy, which is basically how the people who developed it wrote it up based on their research. So when I was at the VA, 2009 to 2010, they were doing a rollout of manualized therapy. So for depression, it was CBT. And then for PTSD, there were 2 cognitive processing therapy, which is better if you have sort of like multiple traumas or long-term traumas, and prolonged exposure, which is better if you have like sort of one singular big trauma. And even therapists who have been treating patients for years and years would have to go into training, get supervision, and back then they submitted VHS tapes, y'all. We were still back in there. Maybe they were the DVDs at that point. I don't know, but physical media to people who were helping with the rollouts and make sure that they were doing the therapy well, and they would get feedback. That being said, if you're trained in CBT, which my program trained us in, it is an easier transition to learn any of those specialized versions of it. You can pretty much pick it up, read about it, understand it, and do it. There's very clear directions. For treatments that are manualized, there's a session by session breakdown. But again, it's also important to remember that individual, like Judy Beck talked in her video we watched on Monday. So a big part of most cognitive therapies is psychoeducation. This is usually what you start with. And this is where you teach clients about the nature of their disorder. So if you're treating someone for panic, you do psychoeducation about what is actually happening with your body in a panic attack. Well, your fight or flight system is overreacting, right? And that's why you get all these symptoms. And you explain, like, the reason why you feel dizzy is the brain actually decreases blood, or the heart actually decreases blood flow to the brain because it doesn't want you to overthink it. It wants you to just react, right? Things like that. I had 2 separate clients in grad school who had panic disorder, but not frequent panic attacks. And that psychoeducation component essentially like cured their panic attacks. It was amazing because like once they understood what was actually happening, they felt much more in control when it did happen. That's not always the case. In eating disorders, we explain, sort of what's going on with your body and your emotions. In PTSD, we explain the model of the therapy. So we explain things like schemas. We explain things like avoidance, like, let's say you get a bill and you're like, I can't pay that right now, and you shove it in a drawer, right? And then you open the drawer a month later, and you're like, oh, there's that bill I never paid. That's essentially what can happen to people with random triggers with their trauma when they try to ignore it. Homework assignments are a big thing. These are things you have people do between sessions, because you are seeing people an hour a week usually. There's a lot more hours in a week, right? So if you're only working on something an hour a week, it's not going to do great. So this is getting people to start practicing the skills or collect more data. So the thought records or ABC sheets we talked about, those are often homework. You might give them behavioral assignments. Go out and act as if you're not sad and challenge yourself to go to a movie this week or something like that. Or doing in vivo exposures, right? Once you've done exposures in session, okay. I challenge you to go on a hike through a well-controlled area, and see if you can get over your fear of snakes for that moment. And then hypothesis testing. Everything is presented to the client as a hypothesis to be assessed within the therapy. So this might be what's going on with you. What do you think about that? And that really feeds into this last point here, that the therapist and the client are going to work together. They're a team. So when I was doing therapy, when I was in grad school, I would tell my clients, you're the expert on you. I'm the expert on the treatment. We're going to work together to help you. And that's really empowering and makes the client feel like they're not just being therapized on, if that makes sense, but they're an active part of their process. And that can help with things like self-efficacy. This is a very abbreviated list. But CBT has been applied to a host of different disorders. So depression, generalized anxiety disorder, panic disorder, phobias, PTSD, eating disorders, personality disorders. So you read Linehan, her DBT is an extension of CBT for people with personality disorders. And as I mentioned previously, I love CBT and it generally tends to work, but it does not work for everybody. I'll tell you story of the client I had that scared me the most. So she, very intelligent young woman. She was in college and art major, very creative. She had type 1 diabetes, and her purging mechanism, her method of trying not to gain weight, was she wouldn't take her insulin. If you know anything about diabetes, that is really, really scary. And so she's actually my client that ended up in the ER more than any other, because she would have like really high or really low blood sugar and need to go in and get treated. And she would not engage in cognitive therapy as it's written. She would not do homework. She struggled against me in session. And so I worked with my supervisor, who's also my grad advisor, to figure out like, how do we help this woman? And so what we ended up doing was just rephrasing things for her. We're not going to call it homework, just like between now and next session, this might help you, right? And just helping her to reframe her insulin. The way she described her insulin is, I feel like when I inject my insulin, I'm injecting fat into my body. Like, of course, you're not going to do that if you have a history of eating disorder, right? So we talked about like reframing it as, like a super serum or, something with powers. And we really had a breakthrough after one session that I felt it didn't go particularly well. She came in the next session and said, I was sitting waiting for my ride after our session, and I imagined what it would be like to lose a foot because of my diabetes, because that can happen with uncontrolled diabetes. You can lose toes and things like that. And that snapped her out of it. And she immediately was more willing to work with me. And by the time I had to leave to go to internship, so if you're at all familiar with the A1C rating, It's essentially like an overall rating of how has your insulin been doing. And hers was so high, they couldn't read it. Like the highest they'll measure is 14, and she was always above that. So when I left to go to internship and transferred her to somebody else, it was at 7. And which was great because her clinic that she was going to, they were like providing her supplies for free and things like that, but they were like, we can't keep doing this if you're not going to be compliant, basically. So they were like, yeah, we'll still work with her. So again, there's an example of someone that like, it just wasn't working. So we had to get creative and figure out how can we actually help this person. If I had just stuck to the manual, she would have stopped, right? And so it's much more important to actually help people get better, right, than to just sit there. So these are some good disputation questions. I often worry that if you worry if yours was true, what does it mean to you and why does it bother you so much? What's the worst that could happen? What do you fear most of all? Is the worst thing likely to happen? If so, how could you learn to cope with it? What do I get out of thinking like this, right? So for people with eating disorders, if you think it's totally fine, it's just helping me lose weight, right? Then you get to sort of like live in this world where you can focus on thinness. How would I persuade a friend? And then working on I accept myself, even though I might not be there. So just real quick, because I am wondering out loud about this myself. There we go. Division 12 of the American Psychological Association keeps a list of research supported treatments. And I just want to see if like, don't have it by modality. Doesn't look like, unfortunately, but you can just sort of see going through here, right? Cognitive adaptation training for schizophrenia. That's what Aaron Beck worked on in the last decade of his life. GAD, depression, schizophrenia, ADHD, anorexia, bulimia, binge eating disorder. Also for physical things, chronic headache, insomnia, irritable bowel syndrome is caused by stress. So if you can work with people to decrease stress, OCD, panic disorder, social anxiety, PTSD, schizophrenia, bipolar, diabetes, people with depression and diabetes. Yeah, that is new content. I hadn't seen that one before. Substance use disorders, right? And then some of these other ones like DBT is a CBT based therapy. So it's used to treat a lot of different things, even things like psychoeducation for panic disorder. Here's an RET for depression. And then if I scroll up a little, behavioral activation for depression. And then all of these acceptance and commitment therapy, that is an extension of the cognitive method that includes things like meditation and mindfulness. So it works for things. So let's just put it that way. Alrighty. Okay, so we do have a group activity, and let me stop sharing for a minute just so I can see how many folks I've got online. Yeah, so I think what I will do is do 2 groups in person and then 3 groups online. And each group will have at least 2 people that way, and assign each group a question. So let me go back into my screen share here. Alrighty, so I will have the 2 groups in person do the ones in the book, just because I have the books for y'all if you don't have them. So let's have, where do we have Sue and Allie and Katie be a group, and then Jada come up to work with Jasmine and Riley. And so have this group be question 1 about Skinner, and have this group be question 2 about Bandura. And then the groups on Zoom, I am going to assign each of you a question. So look at your Zoom room when it asks you to join a breakout room. So Zoom room 1 will be question 3. Zoom room 2 will be question 4 about Beck. Question 3 is about Ellis. And then Zoom room 3 will be Linehan, question 5. And for those people, this is 9, and I have printed out copies for those of you who are here in person. I printed out 4 optimistically. So let me assign, actually, real quick. Folks on Zoom, I'll go ahead and give you a link that'll open a copy for you. There you go. And then I'm gonna go ahead and put you in your breakout rooms. So maybe 10-ish minutes to discuss one question. We'll see how that goes. Come back sometime around 10:30.